Well, good morning, everybody. Good afternoon, depending on where we are in the coast. And welcome to today's webinar. Today we'll be graciously joined by Dr. Jayanthi Parthasarathy, and she'll be talking to us about 3D biomodeling, virtual surgical planning, and 3D printing in pediatric oncology and neurosurgery. A little bit about our guest speaker today will be coming up next, but first, a little bit on our group, the 3D Printing Special Interest Group. As you know, we are part of the RSNA, and our mission statement is to promote the highest quality of 3D printing in medicine through education, collaboration, and research. We focus on maintaining a role for radiologists working together with allied health scientists in this endeavor. So please remember to become a member during the RSNA membership emails that you might be receiving. Please note that the membership for the SIG is not automated. So you can select at the very end of that membership website. We have the QR code down below to remind you to receive the access to webinars and access to the community page. Just another note on our many subcommittees. We have a subcommittee on education led by Summer Decker and Rob Pugliese, as well as the subcommittees on appropriateness, quality assurance, and outreach. So again, check the SIG community page for more details, as these are very active subcommittees. And on today's presenter, we are highlighting two of her many publications. And to know Dr. Parthasarathy, I'm sorry, I'm totally mispronouncing the last name, Jayanthi. She is the manager of the 3D Printing and Innovation Lab at Nationwide Children's Hospital. But her background is immense. She has a background in dentistry, as well as her master's in additive manufacturing and manufacturing engineering, as well as a doctorate in industrial engineering. She has a very active role in the American Makes and NSI Additive Manufacturing Standardization Collaborative, as well as working on the qualification and certification work group for the AMCS. But she also serves as a mentor to undergraduate, medical, and postgraduate students. And her current research interests include materials for 3D printing and simulation of human tissues, as well as the mechanobiology of fluid flow in the vascular system and virtual extended reality for 3D printing applications. Again, I encourage everybody to scan the QR codes, which highlight two of her most recent publications. And again, we'll welcome you to join us, and remember to become part of the SIG.
Thank you, Lumari, for the nice introduction, and I really appreciate this opportunity to meet with so many of our colleagues who work in the same space, and I'm really excited to be here. And as I said, I've been working with this technology last about 25 years, but every day I call it more my passion than my profession, and I'm so excited that this technology is showing us new pathways every single day, that as we look at our patients and how we can help our surgeons. Thank you, RSNA, and thank you everybody for the opportunity to be here today. I have nothing to disclose, and the objective for today's webinar will be, like, we will talk about virtual surgical planning and 3D printing applications in pediatric oncology and neurosurgery, more specifically, and we'll understand the appropriate imaging data acquisition for best outcomes, and we'll also understand the process of biomodeling and virtual surgical planning as related to the pediatric world, because the pediatric world, as we all know, has its challenges of its own. So when you look at 3D printing, we have where we apply them in in biomodeling, we make biomodels, and then which are used as for pre-surgical planning and for understanding the anatomy and giving a scenario to the patient for patient and other educational purposes as well. Then the next step of where we take this takes us to the virtual surgical planning, where we can do all the planning in the surgery, take into all the clinical considerations. And more specifically, we can make the guides, particularly for tumor resections. So these are a few things we'll be talking as of today. And when we look at the specialties that use, of course, any specialty in the medical world, you think they will definitely have an application, but we will particularly talk about neurology and oncology today, neurosurgery and surgical oncology as we see. We'll start with patient workflow because that's the most important thing. Our input data comes either from a red cap or if it is a retrospective study. For prospective studies, we go through Epic. So when they order the CT or MR, they have a question whether they need a 3D model that triggers off the process. And then, which is very helpful after we started with Epic, as we'll see as we move on. So then we do the imaging happens with the assistance of the radiologist, then we do the segmentation and the region growing, then we create the virtual models. And then once we create the virtual model, we use, I go a lot using 3-matics as well as the geometric freeform, which is very versatile and very comfortable to use for organic shapes, as we all know. And then the model is prepared for preprint. Then it's sent to the surgeon back either in the form of a 3D PDF, or they come down to the lab to work with us, or we send a Mimics link where they're able to see. We get the approval eventually, and then it goes for printing, and then the post-processing. Then we have our feedback form. Then we have the surgeons using it in the operatory. So there are several steps as we see, and each step has its own challenges, its pros and cons, and how we manage the whole thing is really important for us to get a good replica, a usable replica of the patient's anatomy. The input is mainly from the CT and the MR, and ultrasound has been used, and 3D scanning has been used. We'll see that how we use the 3D scanning, particularly intraoral scanning, is very useful for orthodontic surgeries. And then photogrammetry is used as well. And for data processing, we have both since we use this for clinical purposes, most of these is approved by the FDA for diagnostic purpose. And then the output comes in the form of mesh files as an STL file, or a model file, or an OBG file, or an PLY, or an AMF, which can be moved, rotated. And creating of these models has a long process, as we will see. So here's a model that is created in using a CT. So all our CTs are invariably volumetric acquired. They're acquired in 3D in form of either 0.5 or 0.625 millimeters. And but of course, when we look into retrospective study, not all the imaging data is stored in packs. So the prospective Epic makes it very effective for us to store this data, even if the model is needed later. So we'll see here is a patient with hyperlordosis of the spine and the anterior pelvis. And we can see how this is being made and used. This is model from a CT. So this is a model from MR. We do a lot of MRs as well, since we do a lot of brain. With this, we use multi-sequence MR for getting these images. So in other cases, we will see what are the sequences we use as well. So here we see a calcified mass in here, and then we see how these are the optic tracts coming up. 3D scanning, we use an RTEC scanner or we use an intraoral scanner. The face tissue, the face scan is used for soft tissue prediction in orthodontic surgery, and dental model scanners are used as well. Now, we'll start off with oncology. Oncology is one of our biggest users, and virtual surgical planning is really very useful for our surgeon, and he sits with us all the time here, where we use the geomagic freeform a lot, which allows us to put the planes and then change colors and do osteotomies real in simple format, and then we're able to translate this back into. So it's basically like a flight simulator where the surgeon sits with us and makes you go through the steps of the simulation of the surgery, taking the clinical input. When we do these kind of things, we always like to use fiducial markers. We use the vitamin E capsules, which are 5 millimeters like spheres, which are very easy to stick on to the patients, because the location where we position them is really important so that they don't move. And this has become much more easier for us after we have the EPIC. So when they have the imaging, the request from the surgeon comes in. So when he asks for the CT and the MR, both are scheduled at the same time. So the biggest challenge was for us was to schedule the CT and the MR at the same time, because the request comes at different times and one imaging has already happened. So with this, we are able to schedule it at the same time, and we are able to place the markers whether CT happens before or the MR happens. They're all happening at the same time and same day, so we're able to put it in the same space. So you can see how this is an MR with the CT markers, and this is a CT with the markers. So you can see how this is placed, and we use the grasp sequence. Since it is placed as part of the radiology, so our radiologists are the best decision makers for what sequence to be used in all this imaging, which has helped us a lot. So the co-registration becomes more precise and easier. So now we see how this is the CT-MR overlay. So you have both. Yeah, you have the, so we say we want a 10 millimeters clearance from the maximum margin, and then so we place these, and then we use a 1.5 millimeters to show the osteotomy. And then here you can see how the osteotomy is done. Then we have the CTA or the CT. So when we have the CTA, we also have the vasculature which comes in, and then we overlay that, and then we do the resection, and we do about 5 millimeters addition of the humerus, so 5 to 7 millimeters, depending on the surgeon's preference. So we are able to show this into the marrow space. So here we come up with the guides based on the resection, and these are the humerus guides, and these are the fibula guides, and this is the post-operative humerus, and these are the guides by themselves. So we can either use a Med 10, or we could use the surgical guide from the form labs to make these guides. Here, this is the resected tumor, This is placed against the model that we made. And this is the resection. This is the post-op where you see the humerus is placed. This is a very complex case of a pelvic chondrosarcoma, where we did a CT MR overlay, again with some of the fiducial markers being placed in strategic positions. Here you see the overlay and how we do a VSP, and this was printed on a polyjet printer, and then this is the post-operative resection piece. And we also do, from time to time, when we get these complex models, we put them back on the CT, and then we do a create a 3D model of them and overlay over the preprint model, and we do a surface contour validation, which we see has been pretty effective, and we have published some papers over that. Here, this is a femur osteosarcoma. So we see this is the resection planned, and this is pretty close to what the resection has happened. There's an MR and a CT, an overlay. Here, the pink part was the actual lesion. The rest what fit was edematous tissue, but the edematous tissue was so adherent to the underlying bone, so the surgeon decided that he will not be able to peel off the edematous tissue, and so he's going to do a resection with that. So we are able to give him an idea of what the actual tumor was and what the edema was. This was our very first case with this surgeon. And so he actually asked for a scapular model. And then I suggested from previous experience that I told him we could do virtual surgical planning, and then we could make some guides for him. And we could also map the bone thickness over there, so he could have the inventory of the screws to be placed right before the surgery. And this was printed on the Formlabs printer. Here the post-op resection. So here's a similar tibia resection. Here we have an MR and the CT. Here's the overlay. And then you see how this is the overlay. And here the surgeon decided to leave a part of the posterior part of the tibia in space, and the posterior and the distal part, so that the patient could have better anchorage of his ankle when they place the implant. And so we are able to give him a good clearance and a nice cutting plane. And we printed the model from Stratasys, our polyjet printer, which is really amazing. This is a femur osteosarcoma. You can see you see this is the overlay. The pink part is the lesion, and that is the resection plan. And you can see how we got the vasculature. Our surgeons now vouch for what they do. This is an interesting patient again with a pelvic tumor. So we planned the resection, and it was an Ewing sarcoma. And after the chemo, there was a lot of shrinkage of the tumor, and they decided to do a reconstruction with an external vendor, and how we'll see how the surgical planning was very useful. So this was the whole post-operative. This was the surgical plan. The whole implant was designed based on the VSP, and the surgeon got all the information, how much of rotation was happening, how much of all of this was happening, and what is the screw placements, and how many suture holes were there. And it was really very amazing for me to be in the OR with the surgeon. And I like to go for almost all of these surgeries. I go so that I understand how the models are used, how the guides are used, so that we could, how we can do things better. This is a recent publication out of this study. Now, after having seen the orthopedic oncology, we go into paraspinal masses. So this is mostly from MR. This patient had, we used multiple sequence of the MR. So we used the T2 for defining the lesion. Then we used the MRV to get the veins. Then we used the 3D MRA for getting the arterial vasculature, the aorta and the neck vessels, because they were so critical, as you would see in the decision planning. So this kid, so these are the ribs. This is the you can see the right clavicle up here. You can see the SVC and the veins. You can see the arch of the aorta and the neck vessels, and this is the trachea. So they were able to get a lot of information. This kid was undergoing robotic surgery, so there was no way the surgeon was going to see anything other than the tumor itself when she does a robotic surgery. It was really, this is the printed model where we printed them in multicolors. And this is the virtual reconstruction, the region of interest, very specifically. This is the intra picture from the robotic surgery. This is another paraspinal mass, a neuroblastoma, which was so close to the vessels, and so they wanted to know the position of the trachea. You can see how this goes. And we used the coronal cube. We used the T2 1 millimeter isotropic slices, which is very specifically done for for our type of work. So the best part of this is being in radiology is all my radiologists are now very familiar with what I need, and the moment they see this protocol, they're able to help us with a great deal. I have no words of thanks to them. Yeah. This is how we move a little down in the abdomen. This is a hepatoblastoma, where the yellow part is a hepatoblastoma, and they wanted to know what the relationship of the hepatic artery and the portal veins and the hepatic vein. So this was our first thing where we planned the resection for them. Of course, there was no making any guides or anything. It was more a visual they used. This is another hepatoblastoma where you see we use the Vibe arterial for the vasculature, and we use the Vibe FS for getting the 20-minute delay for getting the lesion itself. So we can see we can get multiple structures. We can get the aorta, the lesion, then the liver itself, the portal vein, the middle hepatic vein, the bile duct, the right hepatic vein, IVC. It's a lot of information, helpful information for them to plan the surgery. In this particular case, they wanted to know the relationship just of the bile duct and to the lesion. And so we used just the Vibe, 20 minutes delay to get we can see the lesion very nicely here, and then we can see the bile duct. So we put all of them together, and a great help for these surgeons. Now we go to the neurosurgery. Here, as we saw, we'll talk a little bit more about our fiducial markers here. So we have the anatomy. It's the skeletal anatomy and the vasculature was derived from the CTA, and the lesion. This was a very small dermoid cyst on the close to the lateral wall of the orbit, just behind the lateral wall of the orbit, and the rectus muscle was in relationship to the lesion. So the surgeon wanted to know the relationship. So this surgery was being performed by 3 surgeons: the neurosurgeon, the reconstructive surgeon, and the ophthalmic surgeon. So we can see how useful it was. So we took the CTA and got the vasculature. Here you can see the fiducial markers being placed in strategic positions. These positions are they are placed in where the skin doesn't move so much with the imaging, and how nicely you can see these markers on both the MR and the CT. So this is how we do the co-registration, and this is pretty good co-registration. We use 3-matics through the registration. So once it's all done, you can see how the green part is the lesion. Then we have the rectus muscle out there. So the MR was 1 millimeter isotropic. Or the sequences are the best taken. So this is the composite model arising from the CT and the MR. Here we have the printed model, which is printed on the DAP with Stratasys. Here's an encapsulocele and MR. This is the final model, which comes from the composite of the MR and the CT. Here's the printed model. There's another encephalocele which goes both on the so we took the MP range isotopic 1 millimeters and got the lesion and the vasculature. The circle of Willis can be seen here. This again was done by 3 different surgeons. This child also had a cleft palate, as you would see in the model. So we had the neurosurgeon operating on the cranial part of the tumor, the ENT surgeon operating from the through the nasal tract, and the plastic reconstructor was going to do the palate. So there were 3 teams operating on the same on the kid at the same time, and they all needed to know their jurisdiction, and it was really very useful. It was very interesting for me to meet the plastic surgeon for something else. The first day he said, "Hey, I have a model to be done." I said, "Okay, we'll do it." Then the next day morning, I had the ENT surgeon coming in to discuss another case here. He said, "I have this patient." I said, "Oh, I already got this patient." Then a little later, the neurosurgeon came in and said, "I need a model for this patient." I said, "Yes, all of you will get the same model. Will work." It was very interesting to work with this patient. Yeah, you can see how this is the tumor, and then we can see this is the lesion. And the kid also had a cleft palate repair done at the same time. This is a craniosynostosis. I very specifically brought this in because these kids, you can see the cranial vault is so thin, and sometimes it's just about 1 millimeter or even less. And so post-processing these models is a real challenge. And my surgeon wants to have the skull as a whole, and he'll not allow it to split. And even if we split, it's really a Herculean task to put it back in the right space. So we place these struts on the inner side of the skull and give them very different colors. So they are known to be non-anatomical regions. So you can see that these areas are very thin since the deformation of the skull. Here's a meningomyelocele, where this is again a very thin skull. And we had a tongue-like projection, which was literally flapping from the posterior part of the cranium in the center. And so we had to put a lot of these connectors and put them in different colors, as you would see, for a surgeon to understand this is not part of the anatomy. And otherwise, there's no way you're going to hold this in space. So once you get it out, all these parts are going to fritter away during the cleaning process. This is again a multi-sequence MR. We have a strong surgical epilepsy team here, where we take again multi-sequences of MR. We use the MP range for getting the the brain structure, we use the FLAIR for getting that tumor. Here, this is such a tiny little lesion here, and they needed to know how they're going to reach here. So this was again my very first case we did. We use the DTI for getting the neural tracts. We can use the MPRH for getting the vasculature as well. So you can see this is the composite model here. And then our surgeons like us to slice these models at very strategic position that they say. Usually they want it in the center of the lesion, and we slice it and we place magnets, and they're able to put them back together to see the whole brain as a single part. And when they want to see the relationship, they're able to take it out, and they're able to measure from where they want to their access is going to be to the actual position of the lesion, and they can make the best access for them. Here you'll see a calcified lesion, how close it is to the tracts, the optical tracts. This is another case which was published in the BMJ. We use the Fiesta for getting the neural tracts, and then we use the CT, of course. This is a spondylolisthesis patient, and so you can see how this is a preoperative model. And so you can see how much of this is there, and this was published in BMJ. So as I said, we have a strong surgical neurosurgery, epilepsy team, and they also place these electrodes. So they need, at some point, they need to decide where these electrodes are in the brain. So we use both during their fMRI or with the results from the fMRI. So we use the CT and the MR, and we get the electrodes are mapped out from the CT and put on the brain structure in the MR. They use both for research and clinical. This is an interesting patient from my previous work. Here, this as you can see, the part of the cranial bone is eroded. So the surgeon was going to do a craniotomy and then remove the tumor from his end. So we suggested that we could do a virtual surgical plan. And I used to work at MedCAD in Dallas, Texas, where our flagship product was a craniofacial implants, peak implants. So we suggest that we would do a virtual surgical plan, give him a guide, and also make the implant at the same time, so that they could avoid a second surgery later. Otherwise, normally they do the resection, they wait for 3 weeks, then they take another CT, and then they send for the implant. That takes another about 2 to 3 weeks for them to get the implant back from the industry. So all total about 6 weeks, the patient is with the craniotomy opening, and they need to use a helmet. So the surgeon was very excited, and we were able to do this and also give the implant. So a whole surgery was avoided for the patient. This is not from my work, of course. This is a published work where we can use for pedicle screw placement, which is really very interesting. We have started using this in our system as well. This is under review for publication. This is a split calvarial bone graft where we had to map the thickest location where they would have an optimal position where they can split the calvarial bone for placing for closing this void. So, since this patient was a very small kid, this will grow very well. And we were not in for an allograft. So that's the reason why we mapped out the thickest portion of the diplo where they will be doing. In my previous experience, we've done the same thing for doing a malar graft, because it was not published. But so this was interesting for us to do. This is also from my previous work where we gave them a template for the resection from we mirror image from the opposite side and gave them the difference of the for orbital reconstruction, and we gave them this, so they were able to see how much they need to go. I take pride in showing this as well because I used to be an orthodontic surgeon, maxillofacial surgeon, and so a lot of times we used to have a lot of problems in how we do this surgery. This is not truly cosmetic. It is cosmetic to a good extent, but at the same time, the occlusion is of great importance, which these patients miss out on most. So we planned an iPad app exclusive to MedGuide, and I was the chief architect for this iPad app. So we used to do the heavy lifting, get the CTs, and we used to get the models, scan the models using a 3D scanner, overlay it on the CT, and then co-register that, and then do the osteotomies, and do this, put it in the final occlusion, and do the movements for the surgeon. The surgeon could as well tweak and get his best optimal results, what he wanted to do. So this iPad was a part of his, and there used to be a two-way communication. And after he does all the tweaking, the model used to freeze, and we were able to download it from our end and make the final occlusal splints for them. This is a syndromic patient for whom we did a virtual surgical planning. This is again from my previous work, and so we got the STLs from the vendor, placed them, and we gave them a bando device which they could use and for the planning as well. This was an interesting case where we made a peak guide, which was 3D printed peak, and we used Status Direct for that. And the surgeon came and said, I need to do an orbital reconstruction and a zygomatic reconstruction. The lateral wall of the orbit and the zygoma I'm going to reconstruct. And I need to get about a centimeter of bone from somewhere, get me an optimal position. So we got this position, but when we did the design, we came up saying that a 10 millimeter is not going to be sufficient, and you would need a 21 millimeter. This is where I said a virtual surgical planning is the master of decision making in some of these cases. In these cases, it gives them a lot of insight. So we did 21 millimeters, and we gave them the ideal position, and we gave them this guide, and they could do the cut anywhere and get it done. He was going to reshape the cut bone in the OR and get it done. This is again from my previous work where we do a guide for a orbital reconstruction. So this is the cutting guide, and then this is the reposition post-operative plan model. So we can see how we can do that. This is, of course, a lot of us would have read about being this used in cranial reconstruction for quite some time. And it is really very interesting when you see these really complex shapes of the skull being reconstructed in the OR. It needs to accommodate the brain. Same time, it needs to accommodate the orbital. There are too many considerations in this for it to be done without any of this guidance. And I really awestruck how people did without any of this decision makers. Now we come to, again, we look at the liver, where we say we had a portal vein. This is a non-oncology. So I just brought it out here. So you can see this, there was an AVM, there was a portal vein thrombosis, and the patient was not going to go in for any surgery. So the surgeon wanted to explain to the patient's family how essential the surgery was to save the life of the kid. It was a portal vein thrombosis, there was a cavernous transformation. And we couldn't see the right or the left branches of the portal vein. So this was very helpful, in not only in surgery and also as the parents were able to give um, informed consent. So you have a compliant patient after the surgery. None of my talks go without talking about this. This was a very unique experience of mine, uh, where we see these are conjoined twins which were operated at Texas Children's. I'd be there to give a guest lecture, and Dr. Raj Krishnamurthy, a good friend of mine, asked me, hey, we have this conjoined twins, can you help us? I said, of course, yes. So we started off with this, and we took both CTs, MR, made a combined model, a composite model. There were 5 systems involved in this surgery. The kids were sharing a single liver, and then the pelvis, you can see, was completely rotated, and they also had deformities with their kidneys. And the heart of one kid was lying over the liver of the other, or the shared liver. So there was a lot of working that needs to be done. So it almost, I think, took us about 6 to 8 months of planning. And it was a great opportunity for me to learn so many things in terms of design as well as manufacturing. So this was before the DAP days. So this was printed in Object 500. And thank to Stratasys for helping us with this. And we had to find an avascular region where they would be able to split the liver for putting it, for dividing it between the 2 kids. It was a great surgery. And here you can see the models were made as they could be together, or when the kids were separated out. So we were able to take the liver into 2 parts, and these 2 were made as they had a connection with the spine, and which you can see here, which are able to fix back and remove it as well and see. So, and this had to be stable, and this had to bear the weight of both. So it was going to be printed as one piece together. So we had to be considerate of how the cleaning would happen, how the post-processing would happen, how to, because these were really very big models, and how we had to take care of these supports. And they were going to be handled by multiple people. We had to have the vasculature. And when it's being handled over a period of about 6 to 8 months, getting in and out of multiple meetings with so many of these of people touching it and handing it over, it had to be all together. And it had to be in an erect position as they could stand, will be this one. Here is a model, and this is the pre-op planning, and this is the intra-op guidance which they had during the surgery. Coming to printing and materials, we all know that there's a lot of technologies out there, and though the basic technologies have not changed, you had the powder bed, you had the liquid, you had the solid wire. For a long time, the materials has become a wonderful, great lot, which we see more and more applications which we come up with every day. I'm really so enamored by seeing a new application, a new material, a new utilization for new material that comes in. And here in our space, we use mainly the SLA and the DLP. We use the Form Labs, and then we use the multi-jet for our bigger prints. So these are 2 what we use. This is both our workhorses, and they've been doing so extremely good job. Our service request comes either through Epic, and this has changed a lot of our processes in the sense lot of validation and a lot of streamlining the process, make it more easier, triggering off the starting points for many of the people who help us along the way, right from the request to the delivery of the model. REDCap is still used for our retrospective. This gives us a good idea of how we handle our databases. Then, however, for combining images, we always say that we need it prospective so that it helps us in many ways. And then combine it is preferred to do as a combo case with fiducial markers. Then emails and phone calls are still taken up. And it, of course, is followed up with a REDCap request. We have seen there are so many things happening from start to finish, and we need the quality control system cannot be underestimated. And we have to have a robust quality control system. Of course, it means that we put a lot of resources into it, but that is the best thing that you can do to get the best results. Our design verification process, as we said, goes through right from the imaging happens at the CT happens at 0.5 or 0.625. The MR happens at 1 millimeter, and then you're co-registering that. You're doing independent segmentations, you're co-registering in the STLs, so many things happening. So, and then you, as we saw, we needed some struts and we needed some smoothing. We needed to get the preprint models ready. So just before we do the print, all the models come back to are overlaid back on the patient's CT or MR, whatever we used on the original imaging data to make sure that we are good with that. And as we said, from time to time, this is one of our brain models which goes back on the CT or MR. If the image was created from only the MR, then we do an MR, or if it is done from the CT, we do the CT. So we it goes back, then we overlay, we do a 3D contour based. We use the 3-matics is such a helpful tool for this. I can't say anything more than that. And our strengths are, it is part of radiology. And of course, I have been working in this space for more than 20, 25 years, since 97, 98. And then we have our imaging analysts are the best for segmentation because most of them are rad techs. So it's so easy to train them for what we need. And our subspecialized radiologists are involved in every step of the planning and the design. And so they give their thumbs up during, right from the protocol to the segmentation, everything is worked with them. And the collaboration with our research institute, we get some comprehensive solutions. We also have started using the VR. We use the virtual reality mainly for our cardiac cases, but we are in a process where we will start using the VR for VR and AR for other specialties as well. So collaboration with the Simulation Center and Center for Education and Training cannot be underestimated. And we are a strong collaborative network with the best experts in the field. And our lab, the 3D Printing and Innovation Lab, is located as part of Pediatric Advanced Imaging Resource, which is called the PAIR, and it's an integrated facility for advanced imaging solutions. Thanks to our quality systems, this is one of our cases which we published. So he said the model was fantastic. It was really nice. What the model was to be able to see the nerve relation to the bony anatomy. Dr. Bibi, he said, putting the screws, they are two teams of surgery, the orthopedic and the neurosurgery, which we know is really common, that happens all the time. Here is, this is a sinus venosus being discussed by the interventional oncologist and the imaging oncologist. I mean, cardiologist, I'm sorry. The interventional cardiologist and the the physician imaging cardiologist to make sure what he expects from one. These are some of the kudos from our surgeons. These some of our related publications. And this is our team. We have an amazing team out here. I purposely put this person has gone into doing his med school, which he'll be graduating this year. But he was so enthusiastic in working with us as long as he was here. NCH Lab is about 6 years old, and they are still growing every day. Thanks to the Department of Radiology, the leadership, the hospital foundation, which is supporting the lab, and the radiologists, our ad techs, administrative staff, and all the para-analysts, and a whole team of NCH 3D printing, and the hospital and the foundation. And thank you all for a wonderful listening, and I really appreciate RSNA. I was introduced to RSNA SIG only after I joined NCH in 2017. But I'm so glad that this is taking 3D printing to new heights every time we meet. Thank you, and I can take any questions from anybody.
All right, well, thank you so much. That was a wonderful presentation.
Thank you.
I have a quick question, especially as you mentioned the combination of EPIC and RedCap and kind of the structure of your lab. Have you been able to begin the use of the category 3 CPT codes for 3D printing models and guides?
We haven't done it at this point in time, but I think we have to. Our administrator was a bit concerned about using it because it could confuse people who are in the space, but then the billing people. So we were doing the training for them. So we'll be using it shortly.
And also, I saw that you have been working with the teams, trying to get as much as possible the orders when they believe they're going to be using 3D printing, so that it triggers the use of the fiducials and a specific protocol.
Yeah.
How did you guys work with the development of those imaging protocols to facilitate 3D printing?
My radiologist said if I told them that we need isotopic slices, and initially we did have some hiccups with the type of imaging. So I used to go and sit every time the imaging is happening, and the subspecialty radiology would also be there, and then it was a process. It took us some time to get that done. But now I think for most part we are good.
Very good. And we have a couple of questions from the Q&A. First question is, what type of data are you storing in EPIC? And a follow-up question is going to be the process for sterilization of the surgical guides at your institution.
Okay, see, let me just take one question at a time. I'm sorry. The first question was about EPIC, right? We do our basic only input data is stored in EPIC at this point in time. Our PACS is undergoing a change, so once that changes, then we'll be putting the STL in the PACS. But right now, our only our input data resides in EPIC.
And the surgical guides,
the surgical guides, we are still working with that, and we don't use it in the OR right now. I make with them, and they are working with the risk in the hospital, the risk management team, him, and that's a process to go through. We are doing our validations, and
Yeah.
it takes its own time for them to accept things and say that.
Yeah, I
And
think that's universal.
it takes a lot of convincing, and yeah, it takes time.
And another question from the Q&A in terms of the VR and AR solutions. Which ones are you using or considering about use?
We currently use Eleusis. Eleusis has been, we've used it for more than about a year and a half now, and we've done about 50 to 60 patients, because we do it mainly for cardiology, for our interventional cardiology mainly. And it's been really great. And anyway, we do the segmentation for making the 3D model and putting it out there. And we did evaluate the other VR systems as well, but we are yet to offer it to the rest of the hospital. But we gave them an experience, so we put some of the cases, and all of them are excited. But we wanted to sort of go one step at a time and not open up the floodgates and say that where we'll need a lot more resources to handle if we do that.
Very good. And in terms of, you show the cranial synostosis and the cranial cases. The question from the chat is regarding metal 3D printing in the hospital.
Metal 3D printing we don't do, and I don't think we will ever do, because my PhD is in 3D printing of titanium, so I know how difficult it is, and I know it takes a lot of regulatory work to get that done. So that will take a long time. So if it's going to be the point of care, I have my own concern, because it's a whole different ballgame.
Got it. And you mentioned the app that was developed to help visualize. The question from the chat is in regards to using the Mimics viewer and the AI-based cloud segmentation for future work.
AI-based segmentation, I think, will be really good and helpful in reducing the sun, but I think in the training and standardization of the imaging, because is going to be a big challenge, because the same thing when you get for particularly for doing for MR, I would think it'd be really challenging. For the bony anatomy, again, when there is thin bones, it is going to be hard. How we are going to be training it is going to be but I think for certain applications it will be very helpful, so you'll be able to do it your whiz and be done.
Absolutely. Well, we are nearing the end of the hour of this very exciting talk, and again, we want to thank our wonderful speaker for the amazing cases and the great work being done at Nationwide Children's Hospital. We also want to thank everybody that joined us for today's webinar, and we look forward to having everybody join us for our next upcoming webinar, which is another plug for going to the RSNA website and joining the SIG so that you can keep up with the SIG activities in our community page and get the emails regarding our future webinars. So again, to everybody, deep felt thank you, and see you on our next webinar.
Thank you so much. I appreciate the opportunity to be with all of you, the great stalwarts of 3D printing in medicine.
Yes.
Thank you.
Thank you all.